Right now, somewhere in America, a 67-year-old man is sitting at his kitchen table, asking his wife to repeat herself for the third time this morning. She sighs, he apologizes, and both of them quietly blame it on age. But here's what neither of them knows. The pill sitting next to his coffee cup, the one his doctor prescribed 2 years ago, may be the real reason he cannot hear her anymore. I want to be honest with you today because what I am about to share is something that does not get talked about enough inside the walls of a doctor's office. Over 600 medications have been linked to hearing loss and tinnitus, that is the ringing in your ears that never seems to stop. 600. And the majority of the ones on that list are not rare cancer drugs. They are the exact same blood pressure pills, pain relievers, antibiotics, and cholesterol medications that tens of millions of adults over 60 take every single morning without a second thought. The medical term for this is ototoxicity. It means toxic to the ear, and it is one of the most underdiscussed, underdiagnosed, and underreported side effects in all of senior medicine. Here is what the research tells us. A major study that followed thousands of adults aged 65 and older over a 10-year period found that taking multiple ototoxic medications increased the risk of developing hearing loss by 15% for every additional drug added to the list. And those who took NSAIDs, the anti-inflammatory pain pills you will recognize in a moment, had a 45% higher risk of progressive hearing loss compared to people who took none. 45%. Not from some rare drug, from the over-the-counter pills sold in every pharmacy in the country. I am Dr. Daniel Hayes, and today I am going to walk you through 9 common medications that research shows can quietly damage your hearing, especially after age 60. For each one, I will explain exactly what it does inside your ear, which brand names to recognize, what the warning signs look and sound like, and what conversation to have with your doctor before you take another dose. One important thing first. I am a doctor, but I am not your doctor. Do not stop any medication on your own without speaking to the physician who prescribed it. Some of these drugs are life-saving, and stopping them abruptly can be dangerous. Use this video to ask better questions, not to make unilateral decisions. That is the difference between an informed patient and a reckless one. Before we get into the list, I want you to understand something about your inner ear that most people never learn. And once you understand it, everything I am about to tell you will make perfect sense. Deep inside your ear, beyond the eardrum, beyond the small bones, there is a tiny fluid-filled structure called the cochlea. Think of it as a snail-shaped canal coiled tightly inside your skull. Inside that canal, sitting on a membrane, are thousands of microscopic hair cells. They are the most important cells you have never thought about. When sound enters your ear, it travels through the ear canal, vibrates your eardrum, passes through 3 tiny bones, and sends a wave of fluid rippling through the cochlea. Those tiny hair cells pick up that wave. They convert it into an electrical signal. That signal travels along the auditory nerve to your brain. Your brain reads it as sound. Here is the problem. You are born with a fixed number of these hair cells, approximately 15,000 per ear. They do not regenerate. They do not grow back. When they die, they are gone permanently. No surgery can replace them. No hearing aid restores them. A hearing aid can amplify what remains, but it cannot recreate what is lost. Certain medications, the ones we are about to discuss, either destroy those hair cells directly, cut off the blood supply that feeds them, or poison the fluid surrounding them. In some cases, the damage happens in days. In others, it builds silently over months and years until one morning you realize you cannot hear clearly in a noisy restaurant, or your television volume is at the highest setting, or your family is looking at you the way Henry's wife used to look at him. That is the cochlea. Hold that image in your mind. Because every medication on this list attacks it in one of those 3 ways. Now, let us talk about the 9. Number 1. Loop diuretics. Brand names. Lasix, which is furosemide, Bumex, which is bumetanide, Demodex, which is torsemide. These are prescribed for heart failure, high blood pressure, and fluid buildup, swollen ankles, fluid in the lungs, the dangerous accumulation of excess water that can suffocate the heart. They are powerful medications, and in many cases they are life-saving. That is not in question. But here's what happens inside your cochlea when you take them. The cochlea relies on a specific balance of potassium and sodium in the fluid that surrounds the hair cells. That balance is maintained by a structure called the stria vascularis, a network of tiny blood vessels that acts like a chemical pump, keeping the fluid composition exactly right. Loop diuretics disrupt that pump. They interfere with the potassium gradient, the ratio of potassium to sodium inside the cochlear fluid. When that ratio shifts, the electrical environment surrounding your hair cells changes. The hair cells cannot function properly. The signal they send to your auditory nerve becomes distorted or disappears entirely. The research confirms this. A 10-year study found that adults taking loop diuretics had a 40% higher incidence of hearing loss compared to those who did not take them. For progressive hearing loss, meaning the type that continues getting worse, the risk was 33% higher. Warning signs. Sudden muffling in one or both ears, especially within hours of taking a dose. Ringing or buzzing that gets louder after you take your pill. A sensation of fullness or pressure deep inside the ear. In most cases, hearing loss from loop diuretics is temporary and reverses when the drug is stopped or the dose is reduced. But in high doses given intravenously, which can happen during a hospital stay, the damage can be permanent. And if you are combining loop diuretics with other ototoxic drugs on this list, the risk multiplies significantly. Number 2. Non-steroidal anti-inflammatory drugs, NSAIDs. Brand names: ibuprofen, Advil, Motrin, naproxen, Aleve, aspirin in high doses, diclofenac, Voltaren. These are the most commonly used ototoxic medications in the entire older adult population. That same 10-year study found that 58%, more than half, of all older adults in the study were taking NSAIDs. 58%. That is not a fringe drug. That is the pill your neighbor takes every morning for her arthritis. It may be the pill you take. How do NSAIDs damage hearing? They reduce blood flow to the cochlea by blocking a group of compounds called prostaglandins. Prostaglandins help keep the blood vessels that feed the cochlea open and flexible. When you take an NSAID for pain, it blocks prostaglandins throughout the body, including inside the cochlea. The tiny blood vessels that supply oxygen to your hair cells constrict. The hair cells begin to starve. Over weeks, months, and years of daily use, the cumulative loss adds up. The research is clear. Regular NSAID users had a 45% greater risk of progressive hearing loss over 10 years compared to non-users. The effect is compounded when NSAIDs are taken alongside diuretics. Warning signs. High-frequency hearing loss, which means you start losing the ability to hear consonants clearly. Words sound muffled even when you can hear that someone is talking. Women's voices become harder to understand than men's. You mishear words constantly. You hear did when someone said bid. You hear sure when someone said more. That high-frequency erosion is the first fingerprint of cochlear hair cell damage. And it is the most common complaint I hear from patients who have been taking daily NSAIDs for years. Number 3. High-dose aspirin, salicylates. This deserves its own entry because aspirin behaves differently from other NSAIDs in one critical way. At high doses, typically 8 to 12 standard tablets per day, which is common in older adults treating chronic pain or inflammation, aspirin causes a very specific and well-documented form of ototoxicity. It generates reactive oxygen species inside the cochlea. That is the scientific term for unstable, highly damaging molecules that act like tiny fires inside your cells. These reactive oxygen species directly attack the outer hair cells, the hair cells most responsible for the precision and clarity of your hearing. They trigger a process called oxidative apoptosis, which means the cells destroy themselves from the inside. The warning sign from high-dose aspirin is tinnitus, the constant ringing, buzzing, or hissing that has no external source. Many patients describe it as a tea kettle that never turns off. Others describe it as a radio playing between stations, a static hiss that never stops. Research shows that salicylate-induced tinnitus affects the outer hair cells first, which is why clarity of sound deteriorates before volume does. You can hear that someone is speaking, but you cannot make out what they are saying. The good news is that aspirin-induced hearing loss and tinnitus are usually reversible when the dose is reduced. The reactive oxygen species damage is dose-dependent. Lower doses used for cardiovascular protection, 1 baby aspirin per day, carry a much lower ototoxic risk. But if you are taking aspirin in high doses for pain, this is a conversation worth having with your doctor. Number 4. Aminoglycoside antibiotics. Brand names: gentamicin, tobramycin, streptomycin, neomycin. These antibiotics are heavy weapons. They are used for serious, life-threatening bacterial infections: sepsis, severe kidney infections, tuberculosis. Most are given intravenously in a hospital. Some are used as eardrops for chronic ear infections. Aminoglycosides are among the most definitively ototoxic substances ever studied. The mechanism is well understood. These antibiotics enter the cochlear fluid, where they accumulate. Once inside, they are taken up by the outer hair cells. Inside those cells, they generate massive amounts of reactive oxygen species, far more than aspirin does. The hair cells undergo a process of programmed self-destruction. Under a microscope, the cochlea of someone exposed to high-dose aminoglycosides looks like a field after a brush fire. Row after row of hair cells, gone. The damage is almost always permanent. And because aminoglycosides preferentially destroy hair cells in the base of the cochlea first, the hearing loss starts at high frequencies and moves down. That pattern, losing high-frequency hearing first, then mid-range, then eventually low tones, is called the aminoglycoside signature. This is relevant for seniors specifically because older kidneys clear aminoglycosides from the bloodstream more slowly. The drug stays in the body longer. The cochlear exposure is prolonged. the damage accumulates faster than it does in a younger patient with healthy kidney function. If you are ever admitted to a hospital and told you need intravenous antibiotics, you have the right to ask specifically which antibiotic is being used. If an aminoglycoside is necessary, request that your hearing be monitored during treatment. That request is reasonable and medically sound. Number 5. Platinum-based chemotherapy drugs. Brand names: cisplatin, carboplatin, oxaliplatin. These are chemotherapy agents used to treat various cancers: lung, ovarian, bladder, head and neck. They are extraordinary drugs that have saved many lives, but their ototoxic effects are among the most severe of any medication known. Cisplatin damages hearing in up to 75% of adult patients who receive it. The damage is almost always permanent. The mechanism is similar to aminoglycosides, massive generation of reactive oxygen species inside the cochlea, but cisplatin adds an additional layer of destruction. It binds to the DNA inside cochlear hair cells and damages their ability to repair themselves. Even after cisplatin treatment ends, the hair cell damage continues to progress for months. Research on carboplatin shows dose-dependent oxidative damage to the cochlea, with increases in cochlear lipid peroxidation and decreases in antioxidant enzyme activity, confirming that the oxidative mechanism drives the permanent hair cell death. I include this on the list not because there is an easy solution. If you need chemotherapy, hearing loss is a known risk, but because it matters that you know. Before starting platinum-based chemotherapy, a baseline hearing test should be performed. Hearing should be monitored during treatment. And there are emerging protective strategies being studied, including antioxidant compounds that may reduce cochlear damage without interfering with the cancer-fighting effects. Ask your oncologist. Ask directly. What is the risk to my hearing, and are there ways to monitor and reduce it? Knowledge is the first protection. Number 6. Quinine and antimalarial drugs. Brand names: quinine sulfate, used for leg cramps; hydroxychloroquine, Plaquenil, used for rheumatoid arthritis and lupus; chloroquine. Quinine is still prescribed in the United States for nocturnal leg cramps, particularly in older adults. And hydroxychloroquine became one of the most widely discussed medications in recent years, leading to a surge in prescriptions among patients with autoimmune conditions. Both quinine and hydroxychloroquine are ototoxic. Quinine causes tinnitus and temporary hearing loss at therapeutic doses, meaning the doses your doctor prescribes, not overdose. The mechanism involves direct interference with the ion channels inside cochlear hair cells, disrupting the electrochemical signal the cells need to function. At high doses or with prolonged use, quinine-induced hearing damage can become permanent. Hydroxychloroquine carries a lower ototoxic risk than quinine, but long-term use, particularly in older adults with slower drug clearance, has been linked to both tinnitus and mild hearing deterioration. Warning signs: sudden onset of tinnitus within hours of taking a dose, muffled hearing that feels like your ears are plugged, dizziness or a sense of imbalance because these drugs can also affect the vestibular system, the part of your inner ear that controls balance. If you are taking quinine for leg cramps, it is worth having a direct conversation with your doctor about alternatives. Stretching protocols, magnesium, and other non-ototoxic approaches have shown benefit for nocturnal leg cramps and may allow you to reduce or eliminate quinine exposure. Number 7. Certain antidepressants, particularly SSRIs and TCAs. Brand names for SSRIs: Prozac, fluoxetine, Zoloft, sertraline, Paxil, paroxetine, Lexapro, escitalopram. Tricyclic antidepressants: amitriptyline, nortriptyline. This one surprises most people, and it surprised me the first time I read the research carefully. SSRIs and tricyclic antidepressants have been associated with tinnitus in a meaningful percentage of patients. The mechanism is not as well established as the cochlear hair cell destruction we have discussed, but there are two leading theories. First, serotonin plays a role in regulating blood flow to the cochlea. SSRIs alter serotonin levels throughout the body, including inside the tiny vessels feeding the inner ear. Second, SSRIs may affect the neurotransmitter signaling between hair cells and the auditory nerve, potentially creating phantom sounds, which is the neurological origin of tinnitus. Tricyclic antidepressants carry additional risk because of their anticholinergic effects, meaning they block a specific set of nerve signals. Anticholinergic burden has been linked to both auditory processing difficulties and tinnitus in older adults. This does not mean these medications should not be taken. Depression in seniors is serious and undertreated. But if you started an antidepressant and noticed a new ringing in your ears or a subtle worsening of hearing clarity within weeks of beginning the medication, that timing is not coincidence. Tell your prescribing doctor. There may be a lower risk alternative that works just as effectively for your specific situation. Number 8. Beta blockers, particularly certain ones. Brand names: metoprolol, Lopressor, atenolol, propranolol, Inderol. Beta blockers are prescribed for high blood pressure, heart failure, irregular heartbeat, migraines, and anxiety. They work by blocking the effects of adrenaline on the heart and blood vessels, slowing the heart rate and reducing blood pressure. The ototoxic risk from beta blockers is not the same as from aminoglycosides or loop diuretics. It is more indirect, and it relates to blood flow. Beta blockers reduce the force of the heart's pumping action. In healthy younger adults with robust circulation, this reduction in cardiac output is managed well. In adults over 60, who often already have reduced microcirculation to peripheral structures, beta blockers can further compromise blood supply to the cochlea. The cochlea is at the far end of the circulatory chain. It is one of the first places to lose perfusion when cardiac output drops. When the stria vascularis, that chemical pump in the cochlea we discussed earlier, does not receive adequate blood flow, the potassium gradient fails, and hair cells begin to malfunction. The risk is magnified when beta blockers are combined with loop diuretics, which many heart patients are. Both drugs reduce cochlear blood flow through different mechanisms. Together, they create a compounded threat. Warning signs: a gradual decline in hearing clarity over weeks to months while on these medications. Tinnitus that is variable, louder when you stand up, quieter when you lie down, which may reflect the postural changes in blood pressure affecting cochlear perfusion. If you are on both a beta blocker and a loop diuretic and your hearing has been declining, this combination deserves specific discussion with your cardiologist. Number 9. Acetaminophen at high or chronic doses. Brand names: Tylenol, paracetamol. Also found in combination products: NyQuil, Vicodin, Percocet, and dozens of others. Acetaminophen is commonly thought of as the safer alternative to NSAIDs, and for kidney and stomach health, it often is. But for hearing, the data is more complicated. That same 10-year landmark study I referenced at the beginning found that acetaminophen was the second most commonly used ototoxic medication among older adults, taken by 36.5% of participants. And while the ototoxic risk per individual dose is lower than NSAIDs, the sheer prevalence of use and the tendency of older adults to take it daily for chronic pain makes cumulative exposure a real concern. Acetaminophen generates a toxic metabolite called NAPK inside the liver. When taken at high doses or with alcohol, NAPK production overwhelms the body's antioxidant defenses. The same oxidative stress that damages liver cells also reaches the cochlea, where it depletes glutathione, the hair cell's primary antioxidant defense shield, leaving them vulnerable to damage from other sources. One major Harvard study found that regular use of acetaminophen, defined as 2 or more days per week, was associated with a significantly higher risk of hearing loss in men. The association was strongest in men under 60, but the mechanism applies at any age. The danger is especially significant for seniors who are taking acetaminophen inside a combination product without realizing it. Many cold medicines, sleep aids, and prescription pain medications contain acetaminophen. If you take Tylenol and then take NyQuil, you may be doubling your dose without knowing it. The rule: read every label before combining any 2 medications that contain acetaminophen. Do not exceed 3,000 milligrams per day, and if you have liver concerns, keep it well below that. Discuss with your doctor whether your daily pain management plan is inadvertently putting your hearing at risk through cumulative acetaminophen exposure. Now I want to tell you about something the individual medication entries cannot fully capture, and that is the compounding effect. When you take 2 ototoxic medications simultaneously, the hearing risk does not simply add up, it multiplies. The research is unambiguous on this point. Each additional ototoxic medication in an older adult's regimen increases the risk of developing new hearing loss by 15%, and the risk of progressive hearing loss by 9%. That sounds modest per drug, but consider a typical 68-year-old with heart failure, chronic arthritis pain, and anxiety. That person may be taking furosemide, ibuprofen, or naproxen, and a beta blocker simultaneously, every day, for years. 3 ototoxic drugs, 3 separate mechanisms attacking the same cochlea. The loop diuretic disrupting the potassium gradient, the NSAID reducing cochlear blood flow, the beta blocker further compromising circulation to the inner ear. Those 3 mechanisms do not occur independently. They interact, they overlap, and they leave the hair cells with less protection from each individual insult. The cochlea does not announce when it is struggling. There is no alarm, no sharp pain, no test your doctor runs at an annual physical that measures cochlear reserve. By the time hearing loss is clinically detectable, measurable on an audiogram, a significant portion of your hair cells are already gone. So what do you do with all of this? First, do not stop any medication on your own based on what I have told you today. I want to be absolutely clear about that. Some of the medications on this list are managing conditions that are more immediately life-threatening than hearing loss. Loop diuretics keep fluid out of the lungs of heart failure patients. Platinum-based chemotherapy treats cancer. NSAIDs may be the only thing allowing someone with severe arthritis to function. The risk calculation belongs to you and your doctor together. Second, get a baseline hearing test if you have not had one in the past year. An audiogram takes about 20 minutes and gives your doctor a precise map of your hearing at every frequency. If you start a new medication from this list, having a baseline to compare against is essential. If your hearing has already changed, a current audiogram gives your doctor data to work with. Third, go to your medicine cabinet today. Write down every medication you take, prescription and over-the-counter. Look for any of the names I have mentioned. If you see more than one on that list in your daily regimen, that is the most important conversation to bring to your next doctor's appointment. Say these words: I have been watching my hearing, and I am concerned that one or more of my medications may be contributing to hearing loss. Can we review my medication list specifically for ototoxic combinations? And is there a lower risk alternative for any of them? That is not a challenge to your doctor's judgment. That is an informed patient advocating for themselves. Fourth, protect what you have left. If your hearing has already declined, the remaining hair cells are more vulnerable than they were. Avoid loud noise exposure during the same period you are taking ototoxic medications. Noise and ototoxic drugs together destroy hair cells far faster than either does alone. Take antioxidant-rich foods seriously. Leafy greens, berries, nuts. Because antioxidants like glutathione, vitamin C, and vitamin E are your cochlea's natural defense system against oxidative damage. Fifth, ask specifically about monitoring. If you are on cisplatin or an aminoglycoside antibiotic, you have the right to request audiological monitoring during your treatment. Several major medical centers now offer ototoxicity monitoring programs for patients on these drugs. Ask your prescribing physician whether a monitoring protocol is appropriate for your specific treatment plan. I want to leave you with something real. A woman came to see me. I will call her Margaret. She was 71 years old, retired school teacher. Sharp, funny, deeply independent. She had been teaching herself to paint watercolors since she retired. She loved it. But she had stopped going to her painting class at the community center 6 months before she came in. She told me the room was too noisy. She could not follow what the instructor was saying. She felt embarrassed asking people to repeat themselves. She started declining invitations. She stayed home. When I looked at her medication list, I found 4 drugs from the list I have shared with you today. A loop diuretic for blood pressure and mild heart failure. Ibuprofen taken daily for her knee. A tricyclic antidepressant prescribed years earlier. And a combination cold medication she took for her chronic sinuses that contained acetaminophen on top of the occasional standalone Tylenol she was also taking. She was taking 4 ototoxic medications simultaneously, for years. And no one had ever connected that to her hearing. Her cardiologist managed her furosemide. Her rheumatologist managed her pain. Her psychiatrist managed her antidepressant. Her GP managed her sinuses. None of them had the full picture. We were able to switch her loop diuretic to a lower risk option. We eliminated the duplicate acetaminophen. We discussed non-pharmaceutical pain management strategies for her knee. Her antidepressant required a more careful conversation. We found an SSRI with a lower reported tinnitus risk and transitioned her slowly. Her hearing did not improve. The hair cells she had lost were gone, but the progressive decline stopped. Her audiologist fitted her with hearing aids that restored enough clarity that she went back to her painting class 3 months later. She told me the first morning she followed the instructor's words clearly across the room, she sat in her chair and quietly cried. Not because she was sad, because she had not realized until that moment how much she had been missing. Margaret did not lose her hearing to age. She lost it to a list of medications that no one person had ever read together. That is why I made this video. Not to frighten you, to give you the same power Margaret now has. The power of knowing what is on your list. The power of asking the right question. The power of saying, "Doctor, can we look at this together?" Your hearing is not just about sound. It is about connection. It is about being present in the conversations that matter. It is about hearing the voices of the people you love clearly, without effort, without strain, without shame. You cannot get back hair cells once they are gone, but you can protect the ones you have left, starting today.